Afternoon, everyone. My name's Amy. I'm, of course, going to be presenting a little bit of our research from our bone densitometry research laboratory here at Griffith University. So I'm talking about translation from the lab to the clinic and also beyond to implementation, which is the current project that I'm lucky enough to be working on. So I'd also like to, say that I'm acknowledging the first peoples, the traditional custodians of the land. So Jen Gary. I guess I'll jump right in. So first of all, I'm speaking to a pretty well-informed audience about bone and bone physiology and bone tissue here, so I'll keep it pretty simple and quick. We know that from this animal research studies that preferentially bone prefers particular loading stimuli for an osteogenic effect. So that means we need high magnitude loads that are applied at a high strain rate, and they need to be dynamic in nature rather than static. And of course, novel loading applications will be better than those to which the bone is accustomed. So I guess Belinda Beck, my mentor and supervisor, said it really well in one of her papers. The key point is loading must be greater than that to which bone is usually exposed. So then some of our research group back quite a few years ago now looked at the evidence out there and saw that there wasn't that many exercise intervention trials that had actually applied loading sufficiently that was fitting these criteria. So then they set about to rectify that by conducting the LIFT-MORE trial. So that was in postmenopausal women with low to very low bone mass, and they completed a high-RIT protocol where they trained twice per week doing high-intensity progressive resistance and impact training. They saw an improvement in aerial BMD at both the lumbar spine and femoral neck, and this was in comparison to other very low intensity exercise program that was completed at home twice weekly, so matched for frequency, and this was akin to a balance prevention program. Additionally, they saw an improvement in their posture, so a reduction in thoracic kyphosis. And they also didn't see any evidence of vertebral fracture in those that did the heavy loading protocol. There was also an improvement in bone geometry at the femoral neck. Specifically, this was in the lateral cortical thickness, which we know is a site of fracture at the femoral neck. So that was really exciting to see that not only was the high intensity exercise program effective, but it was also safely performed by this cohort. So then I guess we all know the statistic, which is quite sobering, that 1 in 3 women and 1 in 5 men will suffer a fracture in their remaining lifetime after they turn 50. So it was important, I guess, to replicate that exercise intervention that had been conducted in postmenopausal women in men, because we know that while men might not fracture as frequently as women, the post-fracture outcomes are definitely far worse for them. Most importantly, the post-fracture mortality rate in men is significantly higher than in women. So then we replicated the high-RIT protocol in men. Sorry, I got a sticky key here on this keyboard I'm not used to using. So we recruited community dwelling men over 45 years of age. They were, of course, screened for a variety of medications and conditions affecting bone metabolism, and they all had low to very low bone mass confirmed by DEXA. We conducted an 8-month, 3-arm semi-randomized control exercise intervention trial, and the exercise intervention groups, they were block randomized, stratified by the presence or absence of osteoporosis medicines. And we also had rather unorthodox design, but we had a parallel group that were basically continuing with their normal habitual activity. So they didn't receive any intervention, they continued with their normal lifestyle. The 2 exercise interventions were, of course, the high-RIT, which is the high-intensity resistance and impact training program, and then the isometric axial compression, which we can see here with one of our men completing the 4 exercises using the biodensity system. So this is an isometric contraction against fixed external resistance. So this machine was used in the trial because there was not much evidence to show its effectiveness, and we wanted to basically compare that with the high-RIT program. We did do quite a large suite of testing at baseline and 8-month follow-up. I guess for brevity, because I have only 10 minutes, I've just picked out a few of the most important outcomes that we did look at. I know this is quite a messy slide, but I guess the key thing here is that we had 93 eligible participants that were randomly allocated to either one of the exercise intervention groups or allocated or self-selected to control. And we did have a really good retention rate. So we had 88% in the high rate group and 91% in the IAC group. Just with our baseline characteristics, they were quite well matched. They were all of average height and weight. Only 2, unfortunately, in each group were on some form of osteoporosis medicine at baseline, and they continued with that therapy across the trial period as well. The only thing that differed between groups at baseline was femoral neck T-score. So we did see a little bit lower femoral neck T-score in the IAC group in comparison to the other groups. Overall, the compliance was high, so we can see about 78% for the high rate and the IAC groups. We did have 4 falls in the high rate group and 2 in the IAC group. None of these occurred during the training sessions or any of the testing activities. Mostly it was when they were being very silly, doing things that they shouldn't, or actually slipping on a wet surface when they were just out and about, mostly crossing the road on the wet white paint on the pedestrian crossing. So make sure you're careful when you cross the road. There weren't any significant injuries or anything that was associated with the exercise program apart from musculoskeletal discomfort in a very small number of individuals. So I'll move on to the next slide. Sticky key again there. Next, we've got our thoracic kyphosis results. So both the high rate and the IAC groups did have a within group improvement in their relaxed posture. So that was just standing in their relaxed stance. Both of these were actually significant in comparison to the control group. Then at standing at attention, so this was in the second posture, both the high rate and the IAC similarly had improvements in comparison to control and also within group improvements. So overall an improvement in posture. Next for our DEXA-derived aerial BMD measures, high rate had an improvement in lumbar spine aerial BMD in comparison to both control and the IAC groups. And it was quite nice to see that this 4.1% increase was exceeding the least significant change for that site. There were within group improvements for high rate in total hip and femoral neck BMD as well, but that wasn't significant in comparison to the other 2 groups. For trochanteric aerial BMD, high rate did improve in comparison to control, so 2.8%. Looking at the 3D hip geometric outcomes, so this was using some software where we reanalyze standard 2-dimensional DEXA scans. At the proximal femur, we saw an increase for high rate in comparison to both control and the IAC group in femoral neck cortical thickness, and this was at the medial subregion of the femoral neck. This 5.6% increase also exceeded the least significant change. Next, I'll present some of the data from the vertebral fracture analysis. This was from lateral digital vertebral assessment, and we did a Genant vertebral morphology quantification on the 20 of the high rate and 20 of the IAC. So this was just a per protocol analysis. We didn't see any evidence of progression of grading of prevalent vertebral fractures. So those were vertebral fractures that we identified in their baseline scans. So ones that they had existing before they begun the Lift More for Men trial. And I'll just check my chat up there. And then we also had the, oh, sorry, I have a sticky key again here. And I think everything has completely frozen on me. So just one moment. Had lots of technology problems today. No, it seems that I can't progress to my next slide. Oh, there we go. Apologies, I'll continue then. So this is our vertebral fracture assessment data for the IAC group. We did have some evidence of progression of grading from a prevalent vertebral fracture at baseline to follow up. And also 5 incident vertebral fractures were observed at the 8-month follow-up for the IAC group. So I guess trying to summarize, well, I've lost my train of thought with my computer problems here, but overall we saw a high compliance for both the exercise programs, which was really good. No, my mouse isn't working either. So for the high risk group, we saw that lumbar spine and trochanteric aerial BMD improved. Also the medial femoral neck cortical thickness. So we had a positive improvement in bone geometry and a reduction in thoracic kyphosis, so improved posture. There was also no evidence of any progression of vertebral fractures, which were prevalent, and no incident vertebral fractures were observed. I guess we can just give a little thumbs up there to the high rate program. The IAC group did also have an improvement in thoracic kyphosis with a reduction there, so that was good. But unfortunately, we did see the evidence of progression of vertebral fracture and incident fracture as well. So I guess why do we care? Well, after we did these programs where they were very tightly controlled under clinical trial conditions, then we needed to obviously translate this out to the people that need to do the exercise so they can get the benefits. So luckily, Professor Belinda Beck, my supervisor and mentor, established the bone clinic where they complete a neuro exercise, which is essentially the high rate program with the addition of a balance and flexibility and mobility component. So working on falls prevention as well as muscle and bone strength. So this is some data for the first year that people have done their baseline, trained for a year, and then their follow-up with the bone clinic. So they see some really promising results in lumbar spine and femoral neck aerial BMD, and of course improvements in their function across the board. So that's great. So we know that something was effective in the lab under trial conditions, but it was also effective in real world conditions when this was translated into clinical practice. So I love a waterfall plot because I think that it really represents how effective the program is for the majority of individuals that also take part in this in neuro training. So we can see that 78% of clients improve their femoral neck aerial BMD and 82% of clients increase their lumbar spine aerial BMD. So this is really great. So we have good responsiveness with the intervention or the exercise.
Sorry, Amy, we're just at time there. If you've got some take-home messages for your presentation, so we have some time for questions.
Yeah, no worries. I didn't see any chat message come up. Apologies, just being on a different computer. So I guess why do we care? Well, we know that exercise is great for a whole vast majority of different things, and we get all the ancillary benefits of doing exercise. So really, we want to get this out there to more people. So this is where we're going to do the implementation study. So don't worry, this is my last one to wrap up. So we're actually doing a mixed method hybrid effectiveness implementation type 3 study design. So the longest study design name that you can think of. And this is actually focusing on building a whole network of exercise professionals that can deliver the neuro program. And my shameless plug, any endocrinologist or rheumatologist, you can scan the QR code to join the study as a referring clinician. All of the data from the IFMRS trials is available, so you can check that out all online if you like. You can also follow some of our research from our bone densitometry research lab and all of our boneheads, which we are affectionately known. So yes, sorry again about my technological issues today. My laptop decided to just have a complete meltdown. So I guess now we can go through any questions anyone has.
We probably have time only for one quick question. And I can see that there's one in the chat box.
Well, while we are waiting for the raising hand, I have a quick question for Amy. Do you think, can you propose any idea for unsupervised setting exercise training for community dwelling older adults? So we're using the structured program here, but what matters most is implementing that program to the daily routine of the older adults and who are at the high risk of fractures. So do you have any suggestions or proposals for that?
I'm sorry, some of that audio was starting to break up a little bit, but I think it was something along the lines of you were saying doing this on their own or unsupervised.
Mm-hmm. Exactly. So
yeah,
how we can apply
yeah, I guess
on
Obviously, the exercise professionals like accredited exercise physiologists are perfectly placed to deliver exercise programs to individuals at high risk of fracture with osteoporosis. But I think the key to making sure that people are hitting the requisite intensity, so they are in that high intensity range of 80 to 85% of 1RM, is that they do have supervision from a trained professional. But having said that, although not ideal to do it unsupervised, once someone knows the fundamentals and they've done their familiarization and they've become accustomed to doing the movements, I don't think there's any reason why they can't do this kind of program on their own. But I would still suggest supervision, or at least at intervals having a professional like an AEP checking on your technique to make sure you haven't snuck into any bad habits. But I'm all about moving and doing exercise. So I have had some of the men that were in the study that did continue training on their own, and they have done that quite safely because I gave them a lot of really good education about how to do the exercises properly. So I think I've kind of partly answered that, but kind of yes, but no with supervision. And I guess the important thing is that you always need to have the right technique.
Thank you, Amy.
Thank
due
you.
to the time limit, I think we should move on, right, Cass? So
yes, absolutely. So our second presenter is Dr. Kyung Min Kim, a mid-career investigator and endocrinologist working at Yong In Severance Hospital at Yonsei University. Dedicated to bone and mineral research, her academic focus encompasses application of big data analysis in healthcare in the field of osteoporosis fractures, sarcopenia, and aging. Over the years, she gained extensive experience managing patients with osteoporosis at tertiary level institutions and conducting epidemiology studies of osteoporosis and fractures. She's continuing her work with UCSF epidemiology team and from her visiting scholarship to SFCC several years ago. And she has published several important studies in top-ranked journals, including fracture epidemiology and risk factors using the Korean National Claim Database and the application of deep learning on spine X-ray to detect vertebral fracture. She's now serving as head of epidemiology committee of KSBMR. Today, she'll be sharing her findings from her most recent research focus on utilising hospital-based motion data to predict individual fall and fracture risk. Take it away.
Thank you. Can you hear me? Okay.
Yes,
thank you for your introduction. And I'm so pleased to have a chance to share our recent findings on using real-time location systems for prediction in hospitalized patients. Actually, the fall represents a serious complication affecting 1/3 of elderly individuals annually. Especially in hospital falls, are significant concerns in a clinical setting due to their potential for serious outcomes. They often lead to injuries such as fractures or head trauma, which can prolong hospital stays and increase healthcare costs. Therefore, prediction and prevention of falls are crucial for patient safety and effective hospital management. Currently, many hospitals use questionnaire-based prediction models to assess the risk of falls. These models typically involve a series of questions that nurses or other healthcare professionals ask patients. However, these question-based prediction models have several limitations in practical use. First one is subjectivities. The responses can be subjective depending on the patient's self-reporting and records. Therefore, if the patient's memory is impaired, the accuracy cannot be guaranteed. Second, it does not capture the dynamic changes in the patient condition, which can have a significant impact on patient frailty. Third, resource intensive. This model requires significant time and effort from in-hospital staff to administer and interpret. Last, while useful, these models may not always accurately predict falls, particularly in complex cases with multiple risk factors. Therefore, our goal is to develop automatically calculated model to predict the risk of falls using critical parameters from electronic medical records and data from real-time location system. We hypothesized that combining clinical features with RTLS data can significantly enhance the accuracy of risk prediction. Here, let me briefly explain what real-time location system is and how it's used in our hospital. In our hospital, we keep our all-admitted patients with a bracelet that monitor their location and movements in real time. Therefore, this system can track the patient's movement and location in real time. For this study, all admitted patients from 2020 March to 2022 June were retrospectively included. But patients without RTLS data or younger than 50 years old were excluded. This figure presents the flow of patient selection. A total of approximately 22,000 patients were screened. Because the RTLS data was so huge and the numbers of false and non-false patients was highly imbalanced, random sampling was performed for the non-false group in a 1:5 ratio, and finally, 118 full patients and 443 non-false patients were analyzed. For these patients, clinical variables were collected from electronic medical record, including demographics, anthropometrics, vital signs, and routinely performed biochemical parameters, including CBC. Finally, a total of 27 clinical features were included. Also from RTLS data, various features related to patient movement and activity were extracted and created. This figure provides an example of RTLS data from one patient and explains the feature creation process. As shown in this figure, from the information about the patient location every second, patient moving distance, and time it takes to move can be extracted, and the patient moving velocity is calculated from those variables. Through this, the total moving distance per day, total moving time per day, and average daily speed, and the variation of working speed in a day were also calculated. In addition, through the data of all patients, we calculated the cutoff for the top 20% and 50% walking speed for hospital patients, and the proportion of patients moving at a speed above or below top 20 or 50% over daily movement was additionally calculated. And the time during the day with no movement was also calculated. Through this data, the average values of each feature during the hospitalization period for one patient were calculated. For patient who fails, only the values up to just before the full day were included in the analysis. Through this RTLS feature extraction and creation, a total of 28 features related to the patient movement and activities were included in the analysis. To prediction model development, XGBoost algorithm with tenfold cross-validation and hyperparameter tuning were used, and AURC, AUPRC, and Accuracy Extra were used for performance evaluation, and feature importance were presented with sharp values. Let's look at the results of our study. This table presented a basic comparison between patients who experienced falls during hospitalization and those who did not. It was observed that patients who fell were predominantly male, general older, and had extended hospital stays, and were more frequently admitted for medical condition as opposed to the surgical ones. Here, we presented the AUC values that compare the effectiveness of using clinical parameters versus real-time location system features or a combining use of those parameters. As you can see in these figures, even using only clinical features, the prediction accuracy was found to be pretty good with AUC value of around 0.7. However, when predicting falls using real-time location function, the AUC value was significantly higher at a level of 0.82. Additionally, using a combination of clinical and RTLS data, AURC value reaches up to 0.85. This table shows comparative performance metrics for these three models. As you can see here, the model using only RTRS features also gave a quite good performance for all evaluated metrics compared to critical features except the sensitivity. And this increased even further when using RTRS data with combination with critical features. Calibration plot shows the RTRS model either with or without critical features are well calibrated, demonstrating a low speed to data. This feature importance which predominantly affect the model with evaluated using shelf values, and in the RTRS with critical features combining model, patients who exhibited larger total distance on the last day of their stay, or less active movement time, or slower average daily movement speed were found to have a significant influence on fur occurrence. This is the summary and discussion. First, a significant event greatly impacts individuals and overall hospital environment. Therefore, accurate fluid predicting and preventing falls is crucial in patients' care. The RTRS, both with and without biochemical parameters, can effectively predict fall risk in hospitalized patients. Notably, longer distance, less active movement time, and slower daily walking speed is the most significant risk factor for falls, and those parameters could be a sign of patient frailty. Considering that RTRS is a real-time monitoring system, developing and applying an automated calculation system has the advantage of being able to dynamically calculate the risk of falls that changed in real time according to the patient clinical situation. However, this study is just a single-center study and included only small numbers of patients with fall, and we need more larger studies are needed. Conclusion, the combining use of RTRS and critical data offers a significant advance in predicting in-hospital falls, and prospective studies should further address to validate the role of RTRS in monitoring and also preventing falls. Thank you for listening.
Great presentation, thank you. While I'm waiting to see if we have any live questions, we do have a question in the chat. And this is the question here. There are likely to be various degrees of falls, but has the performance changed according to the degree of the fall?
Oh yeah, thank you for a great question. Actually, for divide several categories, because some falls is very minor. Falls do not have any impact over their health condition, but some falls can affect seriously, like fracture, head trauma, or bleeding. But actually, in our data set, the number of falls is really small. So even though we try to separate the falls according to impact or their health conditions, but it is hard to find whether this model predict differently according to the greatness of the fall event. So we are still planning to gather a more falls number for data, and then we develop separate model to predict just fall or fall with any clinical events. Thank you for a great question.
Great, and we'll take one more live question from Yumi Ree.
Oh, hi everyone. Nice work, very interesting. I was wondering whether you had the chance to look at the, which disease they have, and medication might really affect a falling risk, especially in the inpatient setting. So could you explain that to us? Thank you.
Yeah, thank you. It's really great question, X. And we corrected all the medication data from the poor and other patients. And what we found is that the sedative and insomnia drug affect the risk of falls. And now we are analyzing whether those drugs affect their movement or activity when we assess RTRS. But the goal of this study just to check whether RTRS predict falls, and we did not include the results of that part in this study.
Thank you.
Thank you.
Okay, thank you very much, Dr. Kyong Min. We're moving on to Namki now.
All right. Thank you, Dr. Kim. We will now have our keynote speaker presented by Associate Professor Nathan Paplos, who is the head of the Bone Biology and Disease Laboratory and Chair of Research within the School of Biomedical Sciences at the University of Western Australia. He completed his PhD at UWA in 2005 and undertook postdoctoral training between 2007 and 2010 at the Max Planck Institute for Biophysical Chemistry, Germany. As a National Health and Medical Research Council, CJ Martin, overseas research fellow. His current research program focuses on the cellular and molecular pathogenesis of bone diseases, with particular focus on understanding the molecular machinery regulating bone digestion by osteoclasts. Welcome, Dr. Paplos.
Thank you very much. Just share my screen. Everyone see the screen okay?
Yep, great.
Thank you very much for the kind introduction. It's really a great pleasure to be presenting today. I hadn't realized this was the inaugural meeting for the future leaders, so it's really an honor to be presenting. And I've seen a lot of familiar faces online, so it's really nice to see some people dialing in for this. So I approach bone biology through a very different lens. We've just had a couple of nice clinical talks, and really for the most part of my career, I've sort of focused in on these really exquisite and beautiful multinucleated cells that we know as the osteoclasts. In particular, I've been really interested in how osteoclasts compartmentalize membranes and the various molecular mechanisms which help membranes, in this case here, the endolysosomes, transporting small vesicular carriers from one donor compartment to the other. So really for today, what I thought I'd share with you some of the work emerging from our lab, where we've been trying to dissect this really elaborate and beautiful endolysosomal network here, but identify not only new regulators associated with osteoclast function, but they may also serve as potential therapeutic targets for bone diseases. Essentially, just to recap, for those of us who are not so familiar with osteoclasts, these cells are derived from mononuclear progenitors of the monocyte macrophage lineage. So if we give a culture of bone marrow cells, macrophage colony stimulating factor and rank ligand, you'll see that they'll differentiate into these very large multinucleated polykaryons here on glass, and they'll undergo these sort of fission and fusion type reactions. But osteoclasts are polarized cell types, so when we add osteoclasts to bone surfaces, they undergo this polarization cascade, and this is really signified by the formation of this actin-rich region or sealing zone, which allows the osteoclast to adhere tightly to the bone surface, and also underline the bone surface and circumscribe this ruffled border membrane microdomain. It's this domain here which serves as the resorptive organelle of the osteoclast, and also serves as an exit site for both acids such as various proteases, which helps degrade the mineral and organic phase of bone, and that allows it to uptake bone matrix through the process of transcytosis and release this at the so-called functional secretory domain. And we can see the polarization process here. We like to bring our osteoclasts to life, and we've established many live cell assays to do this. And you can see this ruffled border forming here as the osteoclast glides over the surface and their respective functional secretory domain here. And here you can appreciate the dynamics of bone resorption. We have human osteoclasts cultured on bone surfaces, and you can see them gliding over. If we look at this osteoclast up on the top here, you might see it sort of carve its way through and create a pit on the side. So we know osteoclasts are critical for bone remodeling and bone turnover. And in pathological settings, we know that they're associated with increased numbers and activity leads to a downturn or decrease in bone mass, which is associated with osteoporosis, as we've just heard, but also focal bone destruction in the case of inflammatory osteolysis. And conversely, if we disrupt osteoclast numbers or activity, it leads to these sclerosing bone mass conditions known as osteosclerosis, or in this case, osteopetrosis. And it was great to see that Professor Ikigawa is online, who's really an expert and established a lot of the genetics around these conditions. So as I said, the osteoclast is a polarized cell type, and if we take a cross-section through an osteoclast, this is the sort of morphology that we see through transition electron microscopy. And what we can appreciate here is this osteoclast serves as a beautiful model for studying polarized vesicular transport. And particularly in my lab, what we're interested in is studying the transport mechanisms which contribute to the formation not only the ruffled border domain, but also now we're starting to look and interrogate molecules associated with this functional secretory domain, or this domain which uptakes bone and releases it at the surface. So we and others have participated in really dissecting a number of molecular transport pathways associated with osteoclast polarization and the mechanisms involved. And a lot of the work I'm going to present on today is really associated with this unique lysosome-related organelle we refer to as the osteoclast secretory lysosome. And this is what gives rise to this ruffled border domain upon fusion with the apical or bone-facing membrane. So we've developed methods in my lab to visualize the dynamics and formation of the ruffled border. So here we can see during the early phase of the sealing zone or effactin rings, we get this recruitment of lysosomes to this sealing zone domain, and it leads to this structured formation of the ruffled border. But what's surprising to us when we look at this at high resolution, you can see these vesicles tracking into the sealing zone, but in fact, they seem to form these sort of tubular-like structures or interconnected network, which suggested to us that maybe these aren't in fact vesicles, but they're more of a tubular-vesicular phenotype. So at the same time, because these are polarized cell types, we've tried to establish 4D models to study the trafficking of cellular uptake of bone matrix in osteoclasts. The video is just pausing a little bit here, but we can see the movement of bone particulate and exit through this functional secretory domain. And this information allows us to establish these 4D models at the moment, so this is 3D over time, where we're looking at the uptake of both bone particles as well as a release of lysosomal enzymes here in the early stages of bone digestion. And using this information, we can start to integrate this into a contemporary model or understanding of the various vesicular transport pathways, in particular endolysosomal pathways that contribute to the polarization of the osteoclast membrane domains, including this ruffled border here. So my lab's been really interested in trying to understand what are the molecular participants regulating endolysosomal transport in osteoclasts as a way to sort of identify new molecules which can potentially be targeted as anti-resorptives. So really the importance of the endolysosomal pathway is exemplified really in genetic studies in mice and men. So for example, we know that at least 70% of osteopetrosis cases in humans are associated with either defects in endolysosomal transporters or endosome trafficking components. So probably the best examples of that in the case of the TCRG1 mutations, which are associated with a vesicular proton pump, where mutations lead to severe osteopetrosis. But more recently, we and several other groups have also become interested in the endolysosomal protein sorting exon 10, which accounts for a subset of patients. But compared to, say, other well-established secretory organelles, such as synaptic vesicles, and this is some work that was done during postdoctoral studies in the Max Planck, really the molecular anatomy of osteoclast secretory lysosomes is fairly barren and poorly understood. We know that the VATPase and chloride channels are essential, and we're starting to identify a few new components, but really until very recently, the molecular composition was largely unclear. So we set about in my lab to try and address this, and our premise for this was really that these secretory lysosomes, as being a precursor to the ruffled border, should ordinarily share a common proteome with that of the ruffled border, and thus represent potential fertile grounds for the discovery of new anti-resorptive drug targets. So I tasked this to my PhD student, Amy Ribe, at the time, and basically we set about trying to purify secretory lysosomes from osteoclasts. We tried a number of ultracentrifugation methods, which proved very challenging. And what we decided in the end was to adapt a protocol from Walker et al., whereby they generated superaromatic ion particles or spions. And what you can do is you can encourage cells to uptake these through natural and acidic mechanisms, and then exploit the natural maturation pathway from early endosomes through to lysosomes. And we hypothesized that the secretory lysosomes require the unique machinery after this sort of natural pulsating through to lysosomes. So Amy grew osteoclasts, as we can see here, as they differentiate from bone marrow cells into multinucleated osteoclasts. And at pre-osteoclast stage, we pulse the cells with these spions. And after 48 hours, you can see you're getting this incorporation of these black spots of these spions clustering into lysosomes. And what we can do is we can simply homogenize these cells and then capture this through magnetic separation and elute various fractions to enrich these spion-encased organelles. So we validated biochemically that what the organelles were capturing were in fact secretory lysosomes. And so we looked at various lysosomal markers, for example, here. In particular, if we look at a starting protein homogenate, this is a total for LAMP2, RAB7, and cathepsin K, for example. We could see in our enriched fractions here that we're getting quite a high enrichment value. And this gave us some confidence compared to other endosomal, other compartment markers that we had quite a rich population of secretory lysosomes. And so we could put them towards mass spectrometry studies. So this is just paused for a minute. This will move on. There we go. So if we put this through mass spectrometry, we can see here a typical volcano plot, but we're really just interested in this quadrant here, where we have enrichment on secretory lysosomes compared to the starting homogeny. And what we're able to identify was 218 proteins that were significantly enriched on the surface of these purified endolysosomes. So we're just pausing again for a minute. I'll just give it a second. Okay. So really next, to validate whether secretory lysosome proteome was clinically relevant, we assessed the mouse secretory lysosome proteome against the largest GWAS conducted so far for estimated bone mineral density in collaboration with Ben Mullen. And what we found that of the 218 proteins identified, 191 of the human orthologs were enriched in estimated bone mineral density. In particular, we found a number of proteins that we sort of used through various selection criteria, looking at transmembrane transport proteins in this instance, which either showed very strong significance or very strong genome-wide association with estimated bone mineral density in humans. And to our surprise and confidence, from this was really that we picked up TCRG1 as our major high confidence hit, which we know is already associated with the BATPase complex and function in osteoclast. We also picked up a number of other candidate transmembrane proteins, in this instance here being solute carrier protein 37A2 that I'll touch on. And this showed a very high GWAS association with a lead variant in estimated EBMD. So this suggests us that maybe SLC37A2 was a candidate regulator of human bone mass. But what's surprising to us is that most of the literature about the solute carrier 37 protein families is that they're thought to be endoplasmic reticulum localized transporters that function in glucose 6-phosphate transport. And here we can just see the structure of this. But what we found when we looked structurally and also bioinformatically is that SLC37A2 had a number of putative lysosomal sorting motifs at its C-terminal. And it also contained this N-glycosylation loop, which was highly glycosylated. And both of these features are typically associated with lysosomal membrane proteins. So we asked the question, is SLC37A2 in fact an osteoclast secretory lysosome transporter? So to address this, we did our due diligence. We first looked at the expression pattern of SLC37A2 in osteoclast during differentiation and showed that 2 transcripts of it were highly upregulated in response to rank ligand. Not only at the mRNA level, but we can see here at the protein level, you really get this robust induction of SLC37A2 expression during rank line differentiation in osteoclast. And if we look in situ in bone, this is on the endosteal surface and stained for endogenous SLC37A2, you can see it's highly enriched in osteoclast, and here's there's this corresponding sealing zones, but we didn't really see much expression outside in either the bone marrow or in osteocytes or osteoblasts. So we concluded from this that osteoclasts are the major, if not exclusive, source of SLC37A2 in bone. Because SLC37A2 had been previously localized to endoplasmic reticulum, we had to confirm endogenously whether this was localized there. But what we found is clear distinctions between the distribution patterns of SLC and markers of endoplasmic reticulum. On the other hand, we showed very strong association and correlation between SLC37A2 tubular vesicular compartments we see here with lysosomal markers, and they co-localize quite nicely with LAMS, RAB7, and ARL8, and also SLC co-fractionated with these lysosomal markers, again giving us confidence that in fact it's localized to a subset of secretory lysosomes. So if we microinject GFP tagged SLC37A2, we could show that SLC actually corresponds to a very dynamic and tubular vesicular network throughout the osteoclast. And we could confirm by co-injecting other lysosomal reporters or looking at acidified organelles and cathepsin levels that indeed these tubular vesicular structures were bona fide secretory lysosomes. And what was interesting to us when we again cultured these and looked at the dynamics in real time, we found that a lot of these tubular vesicles extended towards the plasma membrane. And we could capture a number of fusion events occurring on the osteoclast that we can see here. So these tubulated acidified vesicles were fusing with the plasma membrane. Now this is on glass, but more importantly, when we look at this on bone, we image at the very plane of the ruffled border, we could see that this SLC37A2 was really enriched and infiltrated the ruffled border domain And also we could capture these sort of tubulation events, which were almost what we refer to as kiss and run fusion events, where you get these extended tubules coming outside, making contact and transinfusion, which is indicative through content release we're getting here, and then rapid recoil. As I said, it's akin to what we refer to as a kiss and run, and suggested that SLC 3702 may be important for maintenance of the ruffle border. So address the function of SLC 3702 in bone homeostasis, we generated SLC knockout mice, and we could already see from plain X-rays that we're getting a widening of the diaphysis, and we could see there was an increase in trabecular bone mass. And indeed, if we take high-resolution micro-CT images of this here, we can see there's really quite a profound increase in trabecular bone mass. There's also some periosteal changes in that as well, which I won't go into today, but as it's already published in the paper. But I will show you sort of an overview of the bone phenotype. This is a 12-week mice in females. You're getting this profound increase in trabecular bone mass, widening of the diaphysis. And if you look at the micro-CT parameters, we can see we've got this really significant increase in both male and female mice, where we're getting increases in trabecular bone density and corresponding decreases in separation. Now, this wasn't only restricted to long bones. We also found it in the axial skeleton and the vertebrae, not so much in the skull, and tooth eruption was normal in these animals. But these mice did show classical signs of cartilage angulae accumulation, which is characteristic of osteosclerosis or osteopetrotic phenotypes. So what this suggested to us that the osteoclast and SLC deficient mice were potentially dysfunctional. And what we found conversely, and was often observed in a number of autosomal recessive osteopetrosis, is that there's this compensatory increase in osteoclast numbers. And what you can see here is each one of these red spots corresponds to a sealing zone or actin-rich ring of osteoclast. So we have this compensatory increase in osteoclast numbers, which is reflected in the increased sealing zone numbers, but also the footprint of these sealing zones was expanded. And here we can just sort of see the, it allows me to scroll through, it's just pausing again. Let's try that again. You can see the sort of spatial organization of the SLC 3702 knockout osteoclasts on trabecular bone surfaces here. So they seem to polarize normally, but they're dysfunctional in terms of resorptive activity. And we can see this here dynamically. So what we can do is we can take osteoclasts from wild type and SLC deficient mice, culture them on bone surfaces, and unlike the wild type osteoclast, which undergoes this centrifugal sort of motion where it bores out resorptive pits and moves quite slowly across the bone surfaces, the knockout osteoclasts are much more rapid and more motile, moving over the bone surface and tend to resorb very shallow resorptive pits. And we can quantify this here, for example, with some work done by Pei-Ying, where we compare the wild type and knockout osteoclast. The SLC deficient osteoclasts aren't completely non-functional. They can nibble a little bit of bone, they just don't do it well. So you can see here, compared to the wild type, which has these nice deep pits, you're getting this very shallow resorption phenotype. And we can look at temporal depth coding, where we can actually look at the depths of these pits, comparing to the wild type, which is really deep. And again, you're getting this very poor or shallow exposure of resorption seen here. So really, to understand the mechanistic basis of what was going on with this osteoclast dysfunction when SLC 3702 was deleted, we set about using a multi-omics approach. And essentially what we did is took osteoclasts and either performed RNA-seq, total proteomics, or organelle-based proteomics to try and look at differences and try and uncover some mechanistic evidence. But really, from this really expensive study, what we were able to confirm is that we had a knockout mouse deficient in SLC 3702, because when we triangulated our data, this was the only significant hit across the database. But what we knew is SLC 3702 was a transporter, and we thought that maybe the substrate is really what's being affected. So we performed untargeted metabolomics. And what we're able to find in this instance is that what we're getting is an overrepresentation of monosaccharide sugars. So in the case of fructose 1 and 2, glucose, but no changes in glucose 6-phosphate, which was the originally purported substrate for the SL37 family. So this suggested to us, does SLC 3702 in fact regulate monosaccharide transport in osteoclast lysosomes? When we looked at lysosomes in the SLC deficient osteoclast, we found that they're morphologically swollen. We could quantitate this and show that they indeed had an increase in size. And what this reminded me of was some classical work done back in the early 80s, where investigators would add sucrose to killer cells, for example, and it would induce a lysosome phenotype akin to a lysosome storage defect. Because sucrose is a disaccharide and can't be excreted or transported through lysosomes, but they know that there's a monosaccharide forms can exit the lysosomes upon the addition of Baker's yeast invertase, which cleaves this disaccharide into monosaccharide forms of glucose and fructose. So we took advantage of this assay, and basically we fed osteoclast sucrose for overnight for 30 hours. And we added Baker's yeast invertase for an hour, and then monitored the dynamics of wild type and SLC deficient osteoclast for 10 minutes. And where we can see in these wild type ones, we get this beautiful tubulation type events extending as the monosaccharides exit the lysosome. That allows relaxation and remodeling of the lysosomes. The knockout osteoclasts remained engorged with this sucrose disaccharide. And so what really this sort of means, to break it down simply, is that as the disaccharide sucrose is cleaved here into monosaccharides, it can exit in the presence of 37A2, but in the case of a knockout, it remains stuck, and so the lysosomes remain swollen. So I know I'm running a little short of time here, but essentially what this means downstream is that basically the disruption of SLC37A2 disrupted endolysosomal trafficking to the ruffled borders and within the sealing zones. So we're getting a loss of endolysomal transport of LAMP2, also cathepsin K into this, and corresponding decreases in the secretion capacity of these SLC deficient osteoclasts. But more so, what we found morphologically, for example, is that really the ruffled borders of the wild type, which normally have these nice fine involutions, were disrupted in the SLC deficient osteoclast. And we can see that here we've got this sort of rudimentary ruffled border forming here, suggesting that SLC 37A2 transporter is really required, at least for the maintenance of the ruffled border. So this has been a rather complicated and busy story, but there's a lot more data that's been published. So I didn't have time to go through all of it today, but really to break down and the take-home message from this animal was essentially that if you knock out SLC37A2, it leads to this compensative increase in osteoclast numbers or dysfunctional osteoclast. There's also changes in coupling, which I didn't have time to go into, leading to this net increase in bone mass. And this is really attributed to SLC's capacity to transport out these monosaccharides and allow this lysosome tubulation. So we concluded from this study that SLC37A2 exports monosaccharides from osteoclast radiolysosomes, and it was a new player involved in bone metabolism. So I don't have really time to go into this data here, but what we're doing now is further functionally validating the osteoclast proteome using a sort of a semi-through high content assays, where we're knocking down a number of the candidate proteins and using elaborate in vitro-based assays in order to screen them. And this just gives you a snapshot of some of the candidates we've got here, some where we have a complete disruption of resorption or acidification, some which lead to excess acidification, but actually impaired resorption in the end. And so we're going through characterizing phenotypes here, establishing various knockout models at the moment, but these are still in their early phases. So perhaps I can present on this next time, and I'll say, let's watch this space. So finally, probably just more food for thought. Can we really target the osteoclast endolysosome network therapeutically in bone disease? I don't have time to really run into all of this, but just suffice to say that carrier proteins are emerging as really an untapped family of proteins to target for a number of metabolic dysfunctions. In particular, we know that glyphosins, for example, inhibitors of the glucose transporter, SLC5A2. So we know that we can target these, but there's a number of challenges we need to overcome, given that these proteins are very difficult to express and to examine crystal structures to inform drug design. Many of them we don't even know the substrate at the moment, so they're orphan transporters. And really we need inhibitors to be able to not only block transporters at the cell surface, but be able to penetrate deep into osteoclast membranes to have function. So with that, I'll just acknowledge a lot of the people involved in this. It's been a heroic effort from a number of people and collaborators, and really the funding support which has made this work possible. And thank you all very much for your attention. Thank you.
Thank you, Dr. Carlos. Wonderful presentation. We have roughly 3 minutes to 4 minutes for Q&A. So please raise your hand or pop up some questions on the Q&A. And while we are all waiting for the questions from the audience, I have one question, Dr. Carlos. So you mentioned that the SLC 73A2 and its role in osteoclast. So recently, a paper published about the function of SLC 37A2 in macrophage modulating inflammation. And they stated that SLC 73A2 might be protective. The physiological role could be protective against suppressing the inflammation, and deletion of SLC 73A2 exacerbated the response to LPS-induced inflammation, inflammatory cytokine release. So can you speculate anything on the systemic effect of deletion or suppression of SLC73A2 in bone related to inflammation cascade?
Yeah, look, it's a great question. I know there's some other emerging work on this. There's also a bit of conflicting data in the space as well. We haven't seen that much of an effect of SLC37A2 on macrophages per se at the moment. We know that if we stimulate them with LPS, it does drive up the expression of SLC37A2. But in terms of the knockout phenotype in macrophages, we haven't observed, at least in our hands, anything untoward in there. Even when we looked at the lysosomal tubulation in response to LPS stimulation, we didn't see any obvious defect in the macrophages. But it's not to say it's not there. I think in targeting from a global perspective, you would have to be cautious of anything where it's systemically expressed. But what we find, at least in our settings, and what we could see from even the in situ staining, is that predominantly the osteoclast is the major cell type where this is expressed. So if we were to look at anything in terms of targeting this, then potentially, it would maybe affect osteoclast on based on the sort of differential dosage.
Thank you. We have another question from Dr. Imai. Dr. Imai?
Yes. Hi, Nathan. Thank you very much.
Thank you. How are you?
Very, very nice talk.
Thank you.
It's wonderful. Yeah. And then, so it means that SLC is like some in knockout mice suppress the osteoclast, not suppress the osteoclast formation, but osteoclast function was impaired, right? So like a cathepsin K inhibitor. So if you develop the drug against the SLC, what is how can I say possible adverse effect for the drug treatment?
Yeah, that's an excellent question. Yes, we're still very much in the early phase, and whether this is really a viable target. I think that given that it tracks very similarly to suppressing cathepsin K, then there's could potentially run similar risk as that's seen in adenocarditab. At the same time, though, the expression of SLC37A2 doesn't necessarily match exactly that of cathepsin K. So it may be the cathepsin K inhibitors were affecting other off targets relative to the targeting here, but it's still very early days. We're looking at a new bone phenotype and a new molecule, and we're looking at next phase of preclinical studies. But depending on how far that will go, only time will tell.
Yeah, thank you very much. Very interesting.
Thank you. So I think it's time to move on to session 2. Thank you, Dr. Papas. And I'd like to hand over the session to Jason. Jason, please.
Thank you, Namki and Cass. So our next presenter is Dr. Oki Jion. Dr. Jion earned her PhD in 2017 from Johns Hopkins University, where she conducted groundbreaking research on senescent cells and their contribution to the loss of musculoskeletal function after injury and as a consequence of aging. She then joined the Buck Institute for Research in Aging as a postdoc researcher, where she discovered the phenomenon of senescence propagation as a new mechanism by which senescent cells rise with age and contribute to aging phenotypes, identifying circulatory pro-aging proteins produced by senescent cells at the root of age-related diseases. She is now an assistant professor at the Korea University College of Medicine, where she is developing innovative therapies for aging and aging-related diseases to target senescent cells. Take it away.
Thanks the organizers for inviting me to give this presentation. Can you hear me?
Yes, we
Yes,
can
we
hear
can.
you.
Yes, yes, we can hear you.
Okay. So thank you. So I'm going to talk about the cellular senescence and therapeutic utility of targeting cells called xenotherapeutics for the musculoskeletal diseases. This slide here visualizes that aging is a key risk factor for the chronic diseases. It estimated that half of 65 years old and have more than 2 conditions that are clearly driven by the aging process itself. So the approach to deal with this problem has been to develop the individual treatment for the disease. But now researchers try to understand the basic aging process and actually target itself in a therapeutic way. So this showed the emerging the strategy for the aging interventions called the rejuvenation strategies. So I categorized the 4 rejuvenation ways. So first one is epigenetic reprogramming of aged cells, and second one is the metabolic manipulation such as dietary restriction and exercise and so on. And third one is targeting senescent cells by using the senolytics or xenomorphic drugs. Then I will talk about it later. And last one is blood manipulations by using the new animal model in the setting of the heterochronic parabiosis, or the injecting the rejuvenative the blood factor, or inhibiting the pro-aging blood factors. So I will present a study written in these blue letters. So I will briefly introduction what is the cellular senescence. So this is just the aged cells. So when cells exposed to the various the complex stress response, the cells undergo this transition into senescent states through P53, P21, P21 and P16 and others, and they develop the 3 distinct phenotypic changes that cells are adapted. The first one is irreversible growth arrest, and second one is they tend to resist to the apoptotic cell death. That's why they do not die but accumulate in the tissue with aging. Another important phenotypic change is that they are metabolically active, meaning that they secrete the SASP into outside of the cells, called the senescence-associated secretory phenotypes. So they act like a zombie cell, like here. So they seem to be present in 2 physiological contexts. And first one is they, of course, increase with the ages, and in addition to this, they are also present at the site of the age-related pathologies. And how could they drive aging phenotype or pathologies? So senescent cell, I already told you that senescent cells secrete the SASP, including pro-inflammatory cytokine, chemokine growth factors, and damage associated molecular patterns, and so on. So what they do is these SASPs affect normal cells by propagating their phenotypes in a parallel manners. The SASPs causes some chronic inflammation in the tissue and age-related pathologies by destroying tissues to drive aging phenotype pathologies. So people, including me, try to develop new pharmacological agents called senolytic drugs, which are selectively kill the senescent cells as well as their secreted SASP factors. So this the paper is the first of therapeutic paradigms to treat the age-related osteoporosis by targeting not just the bone-specific pathways, but rather by targeting fundamental aging mechanism called the cellular senescence present at the bone tissues. So they use actually dasatinib and the quercetin as one of the senolytic drugs traded to the 22 or 24-month-old mouse, and they observed the reduced senescent cell accumulation, which in turn suppressed the bone resorption with either an increased cortical bone or maintenance trabecular bone in the bone formations. So senolytic drugs actually have a lot of potential to treat or prevent the age-related osteoporosis development. Then another application of the senolytic drugs is the osteoarthritis. So this UVX010 is one of the senolytic drugs, and we treated these senolytic drugs to develop degenerative osteoarthritis mouse models, and we killed the senescent cells, and finally we reduced all the inflammation in articular joint space and reduced the pain, and also we got better cartilage tissue repairs. And we also interested into looking at the bony changes under our articular cartilage tissues after senolytic treatment in the post-traumatic osteoarthritis models, but unfortunately, these drugs that we use did not significantly osteophyte formation, subchondral bone sclerosis, and so on. Yeah. So, I would like to switch your gear to some bone blood manipulations. This is the painting of the Lucas Cranach elders in the 16th century who show here a foundation of the youth that would rejuvenate people, so they enter old or flay in the one side, and they emerge the young and rejuvenate on the others. So of course this is not real, but we actually in the real situations, blood serves as a connecting the link for the all organs. So when our body undergo aging on the systemic level, the blood carries factors that are impacted musculoskeletal tissues such as bone, musculoskeletal, skeletal muscles, and cartilage tissues, and interacts with the organs like liver and heart and so on. So we think, how about how can we actually reduce some excess systemic protein with aging called circulatory SASP factors? So first question that we would have SASP factor are actually accumulated in the aged human blood. So by studying with the proteomics and a lot of the cohort studies, we performed that the aging associated protein called SASP factors derived from the senescent cells actually enriched in the aged human blood. So I'm not sure you guys know about the heterochronic parabiosis or the heterochronic blood exchange. It's actually, this is one of the experimental model to understand the circulatory system, circulatory factors that drive the aging or rejuvenate the tissues in the mouse. So actually, there is a people have revealed that the blood of young mice have anti-aging factors that inhibit the aging in the older mouse, while conversely injecting the aged mouse blood or pro-aging factors into young mouse, accelerating aging. So by using these settings, we have a question that maybe old blood, including SASP factor, drive the systemic cellular senescence and then impair the older tissue functions, including the skeletal muscle tissues. So using these blood exchange models, so allow for us for the exchange of blood between young and aged mouse here. So it has we found that all the SASP factors in the aged mouse tissues actually induce the some senescent cellular senescence in the skeletal muscle, for example, the young cell-like cells, compared to the young mouse exchanging the young mouse blood. So we perform the older functional tests for the skeletal muscle, for example, the skeletal muscle strength, or checked some muscle adiposity fibrosis or fatigue or the physical endurance or hanging endurance. So all this, we found that the SASP factor present in the old blood actually induced some cellular senescence in the skeletal muscle and consequently impaired the function of the skeletal muscles. So next question is, can we inhibit the systemic senescence by using the senolytic drugs, which induce some aging, reduce the aging-related phenotypes in young skeletal muscle tissue in the setting of the heterochronic blood exchange systems. So as you expected, when we injected some senolytic drugs, for example, dasatinib, quercetin that I previously mentioned in the osteoporosis application and ABT263. So actually we injected these two senolytic drugs to older mouse, and then transfuse these blood to the young mouse, and then we checked all the senescence SARS marker in the skeletal mouse tissues. So we finally found that all the SARS marker, including P16, P21, other the SARS gene expression, reduced in skeletal muscles compared to young mouse injected with the older mouse blood treated with the vehicle treatment. And also we found that when we treated the senolytic drug to the older mouse and the transfusion to the young mouse, and we inhibit all the senescence inductions by inhibiting the senescence associated beta-galactosidase positive and CD45 positive senescence muscle interstitial cells, and then satellite cells. So finally, we also checked all the mouse functions. And as you expect, the treatment of the older mouse with the senolytic drugs, DNQ or ABT263 before heterochronic blood exchange attenuate the decline in the skeletal muscle functions and reduced the damage to these organs in young mouse receiving the old blood, injecting old blood. So conclusion of this second part is access of the system SARS factors secreted by the senescent cell is detrimental for the tissue health by inducing the senescence-related genes and proteins. So by using senolytic drugs, we can calibrate these age increase the SARS proteins, and then we can create some useful increase the useful protein in the mouse and the peoples. So this is one of the rejuvenative strategies to inhibit the cellular senescence in the systemic level, and then maybe rejuvenate the skeletal muscle tissues. So there are a lot of things that we can we can perform the basic research before entering the clinical applications. So there is no senolytic drugs to affect the target all the senescent cells in the tissues and organs. So, and of course, all the senescent cells are beneficial. Some of them are very good for our physiological context. And third one is SARS. The secret by the senescent cell is remarkably plastic and complex. So we have to think about all the questions to use the senolytic drug in the clinical applications. So this is the conclusions. So senescence is one of the hallmarks of the aging, which is a state in which the cells stop the growing and dividing, and another conclusion is aging appears to be driven by the excess of the systemic factors that secrete by the senescent cells. When we attenuate these senescence secretory phenotype called SARS factor, we can expect to yield a new therapeutic strategy for health span extensions. This is the last slide. Thank you for your attention. I'm happy to answer your question.
Thank you so much for that, Oki. Just in the interest of time, we don't have time for any questions, unfortunately. So if anyone has any questions for Oki, please send her a message through the chat. So we'll just go on to our final presenter today.
Okay.
Okay, let's move on to the next presenter. Our final presenter is Dr. Isis Engin, who is a senior research fellow and the head of the Bone and Muscle Research Group in the Department of Medicine at Monash University in Melbourne, Australia. She was based in München, Germany for 2 years for her first postdoc, looking at the role of ketogenic diets on bone mineral density in a rat model. She then moved to the UK, where she was based at the MRC Human Nutrition Research Unit within the University of Cambridge for 3 years. There she worked on the Zambian bone and muscle aging study, and completed several fieldwork visits to Zambia in West Africa. Upon her return to Australia, she formed her own theme of musculoskeletal health in diverse populations and established studies in various ethnic and patient populations, with an aim to prevent falls and fractures and to improve screening and management of osteoporosis in underserved populations. Dr. Isay, please.
Thanks for that introduction. Here we go. Okay, so Aboriginal and Torres Strait Islander people are the first peoples of Australia. They're not just one group, but rather comprise hundreds of groups that have their own distinct set of languages, histories, and cultural traditions. In Australia, the historical and ongoing effects of colonisation and racism have contributed, at least in a large part, to current inequities to the health and well-being of the First Nations people. So there is an estimated gap of approximately 17 years between First Nations and non-Indigenous life expectation in Australia. The leading causes of death among this population are mental health, diabetes, cancer, and CVD, as well as respiratory disease. One other cause of premature death in this population is fracture. So Aboriginal and Torres Strait Islander Australians have a substantially greater fracture risk than non-Indigenous Australians. So for minimal trauma fractures, Aboriginal and Torres Strait Islander men and women are 50% and 26% more likely to experience such fractures compared with non-Indigenous Australians. Hip fractures also occur at a much younger age in this population when compared to non-Indigenous Australians. So for men, this is 65 compared to 81 years, and in women, this is 74 compared to 83 years. Additionally, over a 10-year period, if we have a look at this graph here, from 1999 to 2008, there was a disproportionate increase in age-related hip fracture rates by 7.2% per year for Aboriginal and Torres Strait Islander Australians, as you can see in the red bars, whilst rates declined by 3.4% per year in non-Indigenous Australians, seen in the blue bars. There's no data on musculoskeletal health knowledge and/or attitudes of Aboriginal and Torres Strait Islander people. So chronic pain is frequently associated with chronic diseases such as osteoporosis and other musculoskeletal disorders. There's been one study, and that was a qualitative study on the perceptions of pain among Aboriginal people from a rural region in Queensland, which is in the far north of Australia on the east coast. And this study revealed that Aboriginal people were reluctant to report their pain due to negative experiences within the healthcare system. Now, this study also reported that the study participants had expressed difficulties in communicating their pain with healthcare professionals and in turn understanding what they were being told due to the use of jargon used by healthcare professionals. So with all of this information that I've just told you, you can clearly see how large the health gap truly is with respect to musculoskeletal health in this population. So therefore, the aim of this work was to co-design an educational program that is culturally appropriate and co-designed with community to not only increase musculoskeletal health knowledge among Aboriginal and Torres Strait Islander people, but also empower them to communicate their pain. Community consultation thus far has identified a need to increase community awareness and understanding of the importance of bone health to prevent fracture and falls among Aboriginal and Torres Strait Islander people. So during the preliminary community consultation, community members explained the importance of integrating their culture and traditions into any kind of program, especially an educational program. So these highlighted the importance of co-designing the educational program to ensure it'll address the needs of Aboriginal and Torres Strait Islander people. So that's when we formed this study called SIMBA, ED, or the Study of Indigenous Muscle and Bone Aging Education. And this was co-designed by Troy Walker, as you can see in the picture there. He's a Yorta man from Northern Victoria, from Echuca, which is one of the states in Australia, just for our international audience, and it's where Melbourne is located, the same state. So together with Troy, we both were required to do a lot of networking and building relationships with key stakeholders, including Aboriginal Health Service managers, community members, as well as elders. So it's important to note that networking and building trust and linking up with community members is a key factor when doing research with Aboriginal people. And if you can't establish these links and build trust, you will not progress, and essentially you will just hit a dead end. And as you can imagine, building trust and networking does take some time. So this project will utilise a bottom-up co-design approach with Aboriginal and Torres Strait Islander community members. Phase 1 of this project will identify the gaps in knowledge and how best to deliver the educational content. And this will be identified through focus groups. And this is what I'll be focusing on in my talk today. So the number of participants per focus group really varied, though we were strict on having at least 5 participants. All study participants were given a $50 gift voucher just as a thank you for their time. Informed consent was obtained. We also asked participants to complete like a little card, which allowed us to collect basic demographics. Each focus group was conducted with a facilitator and an observer. The facilitator guided the discussion in a semi-structured way and prompted participants with questions if needed. And the observer took notes of visual cues or other things that just simply couldn't be detected with the audio recording. The audio recording was then transcribed using Otter AI, and this was then checked by a researcher just to ensure that everything was accurate. Thematic analysis was performed using NVivo. So in total, we conducted 10 focus groups with various Aboriginal health services and community groups across the state of Victoria, as you can see here in the picture. So usually in qualitative research involving focus groups, data saturation is reached within 5 to 6 focus groups, but we think a different approach should be applied with this population. As there are many different groups of First Nations people just in Victoria alone, there's going to be nuanced differences in certain lifestyle aspects. So Troy and I both agreed that we should attempt to gather as much data as feasibly possible from the different regions of Victoria. And of course, we need to do this within a reasonable timeline and within the means of our funding. So in total, we recruited 82 participants in this study, where a large proportion were women, so 64 as opposed to 18. Most of the focus groups were conducted in regional and rural areas. This is due to this population predominantly living in those locations. In terms of education, half of the cohort had finished high school, and about 37% went on to further education after high school, whether it was a trade school called TAFE in Australia or university. Now, the first section of the focus group was based on bone health. So we asked the study participants what they think is important for strong bones. And the main themes that came up were diet and nutrition. Drinking milk came up in all of the focus groups, as well as eating a good amount of fruit and veggies, or vegetables rather. They also mentioned that exercises were good for strong and healthy bones. And when I prompted them to tell me which type of exercises they think were most beneficial for bones, they always started off with walking and swimming. And once I started explaining that swimming is as if, you know, we're in space and that there isn't any load on the bones, on the cells, then a lot of participants straight away would mention lifting weights, which is great because as you heard in the first talk, we know that lifting weights is good for our bones. And so they also mentioned that sleep was important as the body needed to rest. The next question we asked was, what do you know about osteoporosis? So in general, a lot of participants confused osteoarthritis with osteoporosis. Some participants even went on to explaining how swimming helped relieve their pain that they were experiencing from the osteoarthritis. So that was quite interesting. With regards to osteoporosis diagnosis, only a handful actually knew that DEXA or a bone density scan was used. And we also asked whether they knew who had a higher risk of osteoporosis, that is men or women, and participants weren't really sure. They were split in half. Some said men and the other half said women. So it was unknown who had the higher risk. We also asked whether they knew of other long-term conditions or illnesses that affected their bone and muscle health. And so the one consistent one that was mentioned several times in the various focus groups was cancer. And this was potentially due to personal or direct experiences. None of the participants had any knowledge that cardiovascular disease or chronic kidney disease or diabetes actually affected their bone and muscle health. We also ran an interactive activity and asked participants to rank these in order from most to least. And in most of the focus groups, healthy living across the life course was ranked first. We also gave them blank strips for them to brainstorm as a group and list other things that they thought might be important. And they always said mental health. And when we asked them to reorder these strips, they always put mental health first. Sleep, supplements such as iron, protein were also mentioned, and also alcohol and smoking. In terms of setting and how they'd like these educational sessions to be delivered, the group was split according to age. So the older people preferred face-to-face, while the younger people preferred online sessions. Everyone or most of the participants requested visual aids, such as videos or graphics, such as infographics. So what's the next step? We are going to develop the educational program together with our Aboriginal Advisory Committee, who's going to oversee this whole process. And then from each of the Aboriginal health services that we were based at, we're going to be training 1 to 2 healthcare workers from each of the centres, and we're going to provide them with all of the educational content. And so that will be phase 3. And then finally, phase 4, we're going to be rolling out this whole educational program, and hopefully we'll achieve our aims and, you know, increase health literacy among Aboriginal and Torres Strait Islander people with respect to musculoskeletal health. And, you know, the main thing is capacity building. Once this funding runs out, we want to have long lasting effects. And so training the trainers, people part of the community will have the long lasting effects. So with that, I'd just like to acknowledge all the Aboriginal health services, Troy Walker, who's my co-lead in this project, Monash, my university, and Peninsula Health, our funding body, is through these avenues. Okay, that's it. Thank you very much. Yumi, I can see you've got your hand up.
Hi, Eyes. Nice presentation. As you know, Korea is a very relatively homogeneous, homogeneous ethnicity. It is rather very unique that you're dealing with this Aboriginal population. So I was wondering why they have this higher risk and earlier fracture risk compared to other people. Is there any differences in metabolic derangement or any disorders that are different from the people who are living in other regions or with other ethnicities?
That's a really good question, Yumi. Short answer is that there's no data. So that's also another side project that I'm doing, where we're imaging their bones through DEXA and high resolution PQCT, because we simply don't know. What is known is that they do have high rates of cardiovascular disease. And we know that, you know, cardiovascular disease and osteoporosis, there are shared links. Similarly, with chronic kidney disease, this is very highly prevalent in this population. So that can also have a role in, you know, why they have such high fracture rates. Similarly with diabetes as well, but there's no conclusive evidence to link all of these to the actual bone. So hopefully my study will be able to demonstrate this in a few years' time.
Thank you so much.
Thank you.
Perfect.
Okay,
Thanks,
well,
Aisha. Oh, sorry. Thanks,
Sorry,
Aisha. I'll pass you back on to David now, who will close the webinar.
yes, thanks a lot, Aisha. Great presentation to finish up there. And we are slightly over time, so we will close the webinar there. On behalf of the IFMRS Future Global Leaders core group, I would like to thank all the presenters in particular for their time and sharing their outstanding work with us. We also want to thank, obviously, the ANZBMS and KSBMR and our organisers and session chairs who've done such a great job bringing this together for our first in this series. We will be sending a follow-up email with a brief evaluation survey, and we'd be very grateful if you could take a couple of minutes to complete this, as it will help us understand what you all want and help us in terms of determining future initiatives for both the individual societies and the IFMRS. So thank you again to everybody for joining, and have a great remaining time in the week. And we look forward to seeing you at the next one. Thank you.
Thank you. Bye.
Thank you. Bye-bye.